Save lives. Thank you so much for joining us today. My name is Saru Kaiser, and I'm the Education and Mobilization Coordinator here at Breast Cancer Action. Joining me on the webinar today will be Dr. Anthony B. Miller, Professor Emeritus of the University of Toronto's Dalla Lana School of Public Health and the lead author of one of the largest studies on screening mammography to date, the Canadian National Breast Screening Study. A few quick announcements before we get started. Breast Cancer Action doesn't take money from any corporation that profits from or contributes to the breast cancer epidemic. Our work is largely supported by individual donors. Please consider making a $25 donation today to support work like these educational webinars. The presentation of Does Early Detection Save Lives will be a moderated question and answer format. Dr. Miller will first answer some preset questions, and then we'll open it up to questions for the audience. Remember that at any time during the webinar, you can type a question into the question bar. We want you to get involved with Breast Cancer Action, and this webinar is a great way to do that. Please stay tuned for ways we'll mention later on in our presentation. Breast Cancer Action was founded in 1990 by a group of women who were frustrated with the lack of information about breast cancer. Our founders, only one of whom is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard to address the crises. Breast Cancer Action's mission is to carry the voices of people affected by breast cancer to inspire and compel the changes necessary to end the epidemic. Our advocacy is conducted through a social justice lens because the politics and policies of breast cancer disproportionately affect poor women and women of color. Breast Cancer Action's independence from pharmaceutical company funding puts us in a unique position to address issues of health equity and exposures of toxins in our environment, as well as putting the needs of patients before pharmaceutical company profits. We have three main program priorities. The first is putting patients first. We will work at the Food and Drug Administration in favor of treatments that are less toxic, more effective, and less expensive than those already available. We also provide information about breast cancer to anyone who needs it. The second is creating healthy environments where we work to reduce the involuntary exposures people encounter that put them at risk for breast cancer by holding corporations accountable for unhealthy products and practices. We also support legislation that would better protect us from chemicals in our environment and that would make personal care products safer. And last is eliminating social inequities related to breast cancer, where we work to create awareness that it is not just genes, but social injustices, political, economic, and racial inequalities that lead to disparities in breast cancer incidence and outcomes. Our presenter today, Dr. Anthony B. Miller, is Professor Emeritus in the Dalla Lana School of Public Health at the University of Toronto in Canada, and he's the Director of the Canadian National Breast Screening Study. After training in internal medicine in the UK, he joined the Medical Research Council Tuberculosis and Chest Disease Unit. He was Director of the Epidemiology Unit of the National Cancer Institute of Canada and Chairman of the Department of Preventative Medicine and Biostatistics in the University of Toronto. He served as Special Expert in the Early Detection Branch, Division of Cancer Prevention, U.S. National Cancer Institute, and was the Senior Epidemiologist at the International Agency for Research on Cancer in Lyon, France. And he has served as the head of the Division of Clinical Epidemiology at the German Cancer Research Center. He has also been a consultant to the World Health Organization on cancer control and to the U.S. National Cancer Institute on cancer screening, working on both the prostate, lung, colon, and ovary trial and the National Lung Screening Trial. He is scientific lead of the Cancer Risk Management Initiative of the Canadian Partnership Against Cancer and a member of the Partnership's Cancer Control Council. Welcome, Dr. Miller.
Thank you. Pleased to be here. Well, today I'm going to talk about the Canadian National Breast Screening Study, which was initiated in Canada in 1980. Before we go too far, let's just give one or two definitions. I think we all know what mammography is, but let's remember that it may be used both as a screening and a diagnostic test. Now, by screening, we mean the use of a test to detect early disease in groups of people who do not know if they have a disease, whereas diagnosis is the use of tests in people who have symptoms or who have a positive screening test to determine if disease is present. We're also going to mention lead time. This is the time by which screen detection, the detection of breast cancer by a screening test, mammography, breast examination, breast self-examination, brings forward the diagnosis of breast cancer. And we will also refer to cancers that are screen detected. That means they are found as a result of screening, of the use of a screening test. But they're also, when you have a screening program, there are cancers that are found after a normal screening test before the next test is due. And we call these interval cancers.
Thank you, Dr. Miller, for giving us some definitions before we get started. Now, the Canadian National Breast Screening Study is one of the largest well-designed studies of screening mammography. Can you give us a little bit of background on this study?
Certainly. The background is that in 1974, there was a special committee established by the Canadian Association of Radiologists to look at the use of mammography in Canada. This was because an earlier study, I'll mention later, had suggested benefit in women over the age of 50. And they recommended that a Canadian study of the evaluation of breast screening should be conducted. So we started planning the study at that time, did quite a lot of work, and then in 1978, a special working group that reviewed projects in the United States called the Breast Cancer Detection Demonstration Project in many cities throughout the United States recommended that a trial to evaluate the magnitude of benefit and net benefit risk in the use of mammography screening should be conducted. This was because they had used in their breast cancer detection demonstration project the combination of mammography and breast examinations, and it was not possible to find out which was beneficial. Now, in fact, this recommendation was taken seriously in Canada, and we modified the design of the National Breast Screening Study to take note of this. But unfortunately, there was no study initiated in the United States. Our study in women aged 50 to 59 is therefore the only trial designed to provide this necessary data as recommended by that working group in 1978. Let's give you more data that was available at that time. In 1973, there was a report of a special trial in New York in the health insurance plan of Greater New York, and this showed that screening by mammography and breast examinations, clinical breast examinations, was effective in reducing breast cancer deaths in women aged 50 to 64, but they did not find a benefit in women aged 40 to 49. And then before we started the Canadian study in 1980, 2 mammography trials were ongoing in Sweden, but no results had been reported. But most importantly, already modern adjuvant therapy, chemotherapy and hormone therapy for breast cancer was freely available in Canada, but at that time it was not available in Sweden.
Thank you for that background information. There have been a number of foundational studies of screening mammography, of which this study is one of them, and they all have had some varying results. Can you tell us what you feel are the important and unique aspects of the Canadian study?
Well, the first thing I think we've got to remember that our objectives were different from these other trials. We were evaluating the efficacy of screening. By efficacy, I mean the extent to which screening results in reduction of deaths from breast cancer by mammography and breast examinations combined in women aged 40 to 49. And this was the first trial specifically designed for this age group. And then, as we've already implied, we evaluated how much mammography adds to the efficacy of screening by mammography and breast examinations in women aged 50 to 59, the only trial designed with this objective. It's useful to see how we went about this trial. We recruited women who volunteered to the trial with informed consent. They volunteered to participate knowing they would not necessarily have mammography, but that it was a special research study. And we recruited very close to 90,000 women from across Canada. When the women came into the screening centres, they were given a breast examination by a specially trained examiner, nurses in most of the centres, but physicians in the province of Quebec. And then for women aged 40 to 49, of which there were just over 50,000, they were randomized by the centre coordinator by a special process we set up to either have mammography plus breast examination, and we call that the mammography arm, or what we call usual care. By usual care, we mean that the women did not come back to the screening centre. Instead, they were expected to stay under the care of their family physician. If they had any problems with their breasts, then they were asked to go and see the family physician. And we followed them by mail. They sent us a questionnaire every year. For the women aged 50 to 59, there was just under 40,000 women, again randomized within the centre by the coordinator, and they either had breast examination alone without mammography, though mammography could be used for diagnosis if necessary, or the combination of mammography and breast examination. Now, as a result of this process, there were more invasive cancers, breast cancers, detected during the 5-year screening period in the mammography arm than in the control arm. The actual numbers, 666 versus 524. In the mammography arm, 484 of these 666 were detected by screening, of which 142 could not be palpated, i.e. they were found by mammography alone. The palpable cancers in both arms, the mammography arm and the control arm, were larger on average than the cancers that could not be felt in the mammography arm, nearly twice as large, over 2 centimetres, compared to just over 1 centimetre. And this is what happened in terms of breast cancer deaths. Over the whole period of the study, starting in 1980 to 84 and going through to 2005, a 25-year follow-up, there were deaths from breast cancer in both arms, but they were almost identical. 505 in the control arm, where mammography was not used for screening, 500 in the mammography arm. That is a very insignificant difference. So mammography, the use of mammography did not reduce the deaths from breast cancer. If we go to the next slide, this relates to the deaths from breast cancer that occurred during the screening period. That's the first 5 years. Again, identical, almost identical numbers, 171 in the control arm without mammography, a little more in the mammography arm, but that was not significant. This could happen easily by chance. And so there was absolutely no benefit from the mammography screening. So our conclusions are there was no difference in the numbers of breast cancer deaths between the two arms, whether considering only the breast cancers diagnosed in the 5-year screening period or in the whole period of follow-up. And this was true both for women aged 40 to 49 and those aged 50 to 59. Thus, the addition of mammography to breast examinations did not reduce deaths from breast cancer.
Thank you. So the findings you presented are really important and potentially can change the way that countries screen for breast cancer. We actually saw recently that the Swiss Medical Board recommended that mass mammography screening should be abolished in Switzerland. Can you tell us more about how this study, the Canadian study, adds to our current knowledge about breast cancer screening?
Well, one of the most important things is it enables us to identify some of the potential harms from screening. And I'm just going to show you the data from the Canadian National Breast Screening Study in this regard. The first thing is that people are concerned about is that the test may not find cancer. Women may be told that they don't have cancer and they get false reassurance. We measure this by the numbers of interval cancers detected as a proportion of the screening test performed. In the mammography arm, there were 6 per 10,000 women, interval cancers. In the control arm, 11 per 10,000 women. So in this circumstance, the use of mammography reduces false reassurance. But we've got to remember, even though this is so, and many would regard this as a benefit of mammography, there was no change in the numbers of deaths from breast cancer, so that this really had no impact on mortality from breast cancer. The second potential harm I want to discuss are the complications from investigations of false positive tests. If you do screening tests, a number are found to be abnormal, but they are not found to result in a diagnosis of cancer. So we measure this by the numbers of abnormal screening tests, less the numbers of screen-detected cancers as a proportion of the screening tests performed. In the mammography arm, there were 9.7% false positive. In the control arm, 8.1%. So in fact, the use of mammography increased the false positives. So that was a detriment from the use of mammography. So mammography increases the numbers of false positive tests. The other thing I want to remind you, and this is people often forget, is that case detection, the mere finding of a cancer as a result of a screening test, is not equivalent to benefit. It does not mean the woman would necessarily have been benefited. And this is because, for one thing, the detected cancer may not in fact be curable, nor have its natural history modified by available treatment. I put this in terms of what people normally talk about mammography. From some of the other studies, the older studies than ours, they may say that mammography reduces breast cancer deaths by 30%. But you've got to remember that means that 70% of the breast cancer deaths were not influenced by mammography screening, and that's what we mean here. The other issue is that the detected cancer may never have become life-threatening in the patient's lifetime, either because it is cured. Many breast cancers are cured even though they're not found by screening, or they are what are called overdiagnosed. Now, what do we mean by overdiagnosis? It's useful to think of this in terms of the 3 different types. One type is that the cancer, though found by mammography, in fact, if you had left it alone, it would not have continued to grow, it would have gradually disappeared. And there have been some estimates, derived particularly from Norway, that this has happened. The second is that the cancer progresses too slowly to be life-threatening in even the longest of lifetimes. So this is a cancer that grew up to a certain point, then the body defense mechanisms came into play, and it stopped growing quickly, became growing too slowly, and it would never have harmed the woman. And the third type is a little difficult to follow, but this is, although the cancer progresses quickly enough to be life-threatening during a normal lifetime, death due to a competing cause, another cause of death, occurs prior to the date when this cancer would have been diagnosed by symptoms if screening had not occurred. And this happens because, unfortunately, people do die, accidents occur, people die of heart attacks or falls, and of course that occurs more and more often as people get older. So these are the three types of overdiagnosis that we've encountered. Now, when we look at how the breast cancers accumulated, the numbers that gradually increased in the mammography arm, as we see here, during time, and in the control arm, you see the mammography arm, you get this gap, which is because more cancers are being found by mammography. There's a little bit of what we believe is chance variation, but throughout the period of follow-up, there is this difference in numbers of cancers between those found in the mammography arm and those found in the control arm. So we can use that to estimate overdiagnosis. From the Canadian study, we believe that 106 invasive cancers that were detected by screening were overdiagnosed. Now we know that we had 484 screen-detected cancers. We know we had 212 invasive cancers that were detected by mammography, but they could not be felt, which means that 22% of these screen-detected cases were overdiagnosed, but half of the impalpable cases detected by mammography were overdiagnosed. And that actually works out as one overdiagnosed invasive breast cancer for every 424 women who received mammography screening in the trial. Now those estimates were for invasive cancer only, but we've also done separate estimates, including in situ cancer, that's lobular carcinoma in situ, and ductal carcinoma in situ. They're not invasive, but radiologists believe that it's a good thing to find these cancers, though in fact no one has ever been able to show that finding them and removing them reduces the subsequent incidence, the subsequent occurrence of invasive cancer. This is what we would expect. We would expect for other cancers, cancer of the cervix, for example, you remove carcinoma in situ and the incidence falls. For colon cancer, you find adenomatous polyps, you remove those and incidence falls. But this has never been demonstrated for breast cancer. Now, if we count the numbers of overdiagnosed invasive and in situ cancers, it goes up to 206. The number of screen-detected invasive and in situ cancers, 589, which means that 35% of the screen-detected cases were overdiagnosed. If we look at this in terms of the numbers of impalpable cases, because all these in situ cancers were impalpable, the number goes up to 72%. So this is really rather serious. The implications are that a number of cancers found by mammography screening are overtreated, that our previous estimates of the lead time, the amount of time we gained by mammography, were wrong. It's approximately a year, not as we used to think 4 years. And that, in fact, impacts on our understanding of the natural history of breast cancer, which is quite long. If you can only backdate the time of diagnosis by a year, it's not surprising. It doesn't have much impact on deaths from breast cancer. But what we do need now are research on various biomarkers, as we call them, molecular markers, so we can identify overdiagnosed cases so we don't have this unnecessary treatment.
Thank you. So your study has been challenged since it's been presented, both most recently with the 25-year data, but sort of all through the period of presenting the information. Can you talk a little bit more about what you see are the limitations of the study as well as some of the challenges that have been claimed?
Certainly. The first thing is that women older than 59 were not included. And but we believe, there is no reason to believe, that the null effect of mammography we found in our study does not apply to women older than 60. There's no particular change in the way breast cancers behave between 59 and 60 and 61, whereas there is a change in the way breast cancers behave with the menopause, which is approximately at the age of 50. However, there are some reasons to fear, because of competing causes of death, that overdiagnosis may be greater in women older than 60. The other thing is, inevitably, as we conducted the study, we screened from 1980 to 1988. We used the mammography that was available of the 1980s. Now, we took a lot of care to ensure that the mammography was done well, but we have to point out that the other trials on which people depend to show that mammography reduces breast cancer death use similar or older mammography. So our cancer detection rate, we found as many cancers as these other trials did. The other thing is that the way we allocated women, which I described to you before, we recruited women who volunteered for the trial. Some have criticized this. They say we should have simply allocated women from population registers. Well, this is not something you can do in North America. It can't be done in the United States or Canada. But we did have an independent review of our randomization method conducted for the Canadian National Cancer Institute, and these consultants, these experienced epidemiologists, confirmed the appropriateness of our procedures. The other thing we've got to remember is this was randomization with informed consent. Women knew what they were doing. We also have data on all participants that confirms that the groups were balanced. That means we had equal numbers in both arms with the various breast cancer risk factors. For example, family history, age at menopause, numbers of children, smoking, and so on. And we also have the confidence of knowing that the process we set out was that if the examiners, either the nurses who did the examinations or physicians in Quebec, suspected an abnormality, or the radiologist suspected a mammography on the mammograms, these women were asked to attend a special review clinic at the first screen run by the study surgeon in each center. And we know how many was referred for abnormalities, and they are absolutely equal in the two arms. So that we don't have a problem in terms of unequal randomization in our view. Although you will hear radiologists who disagree with me, but that's because they don't look at our data. The other thing is the death rate, both from breast cancer and from all causes of death, whatever the cause, was the same in both groups for the 25 years. If our groups had ended up unequal, unbalanced, then you would not expect this at all.
Thank you for addressing those both limitations and concerns of the study. The conclusions of your study are very important for understanding the limits of screening mammography. And since this is a study of Canadian women, can you talk a little bit about how these results can be applied to the diversity of communities we have here in the U.S.?
Certainly. I believe they can be applied very well, but we have to remember that the information disseminated to diverse communities has to be compatible with the community's culture. And although there are women at risk of breast cancer in every community, the degree of risk varies. So some women may feel they're more at risk than others and may wish to take more actions than others. That's their choice. Canada's universal healthcare system certainly means there are no financial barriers to assessing appropriate care. But from here in Canada, we've watched the process of trying to ensure the Affordable Care Act is passed in the United States, and we feel this is very important, particularly for people who lack health insurance or don't have adequate health insurance. And we look forward to the time when there may be no financial barrier to assessing appropriate care in the United States as in Canada.
Thank you, Dr. Miller. I think that last one is really important in terms of thinking about the difference between Canadian populations and U.S. populations, and hopefully the Affordable Care Act will help with some of that, but I think that's something important to remember. You've clearly laid out the findings of your study, which found that there is no difference in mortality between women who have had mammography and those who didn't, but that overdiagnosis was a really significant concern in the mammography group. Can you talk a little bit more about important takeaways from the study?
Yes, well, I would like to relate this to what I call the conclusions. And the most important is annual mammography does not result in a reduction in breast cancer specific mortality for women aged 40 to 59 beyond that of physical examination, breast examinations alone, or usual care in the community. Annual breast examinations for women aged 50 to 59, usual care under the care of the family physician in the community. So in my view, the value of mammography screening should be reassessed. And what we've identified is overdiagnosis is a serious consequence of mammography screening, and research into its amelioration and reduction in overtreatment is urgently needed.
Thank you for those conclusions. And I mentioned earlier that there are a number of foundational studies of screening mammography. Can you talk a little bit more about these studies and what their findings have been?
Yes. Well, let's summarize the trials that were done of mammography alone. In Sweden, there were 4 such trials in the cities of Malmö, Stockholm, and Gothenburg, and in 2 counties in rural Sweden, north of Stockholm. They commenced the Malmö study in 1976, the 2-county study in 1977, therefore both before our study, and the next 2 during the period our study was ongoing. Only in the 2-county trial, which started in 1977, was a significant effect of mammography screening found. There was also, in the United Kingdom, what they call an age trial. This included women just 39 to 41. It commenced in 1991, and they recruited women through 1997 in their existing screening centres in the United Kingdom, and they followed them for 7 years, and they reported after 10 years a non-significant reduction in breast cancer deaths, a relatively small reduction which was not significant, even though this is a very large trial, indeed much larger than ours, almost 200,000 women. Now, I would like to make 1 or 2 comments on the Swedish trials used to justify mammography screening. In one overview analysis conducted, they only found benefit for women aged 60 to 69. So we have to slightly worry about this because, as we already stated, we didn't study women aged 60 to 69. But in fact, there are some reasons to be concerned about this, because several of these trials use what we call cluster randomization. They didn't randomize women individually. They randomized them in groups. And when this was particularly true for the 2-county trial, and when you do that, it's very uncertain whether you have balance between the groups. So the balance between these compared arms has not been confirmed. And as I said much earlier, modern adjuvant therapy was not available. The other thing I want to comment is, and we see people fairly often point this out, if you look at trends in breast cancer mortality, in a number of countries. Canada is this green line here. United States is this purple line here. United Kingdom goes up to a peak. The Netherlands goes up and then eventually comes down. And here is Sweden, and here is Finland, the orange line. And something seems to have happened about 1990 or just before 1990, particularly in the UK, Canada, and the United States. And what happened at that time was the effect of adjuvant treatment. Now, many would like to think these falls is due to mammography, but there have been a number of attempts to evaluate this, and they haven't been able to show that mammography is the important cause. The important cause of this is treatment, improved treatment. In Sweden, which was slow bringing in improved treatment, you had a gradual fall, but nothing dramatic as in other countries. And in Finland, which in fact didn't introduce screening much earlier, you had no real effect until possibly a little later on.
Thank you for summarizing some of these other studies and their findings. You've presented a great amount of information and given us a lot to think about. I wanted to see if you had any lost thoughts before we open it up for our audience for their questions.
Well, I just want to repeat some of these conclusions. In the Canadian National Breast Screening Study, death rates from breast cancer were the same in women who got mammograms and those who did not. 1 in 5 breast cancers found by mammography screening and treated did not pose a threat to women's health. There is no benefit, we have demonstrated, to finding breast cancers before they can be felt. And we've got to remember that studies showing a benefit from mammograms were performed before improved treatments for breast cancer were available.
Thank you so much. I wanted to take a moment to review some resources that might be useful in thinking about this subject a little bit more. So the first is if you're interested in reading the full study, you can find Dr. Miller's research, the 25-year follow-up for breast cancer incidence and mortality of the Canadian National Breast Screening Study, at the British Medical Journal. It was published February 2014, and it is available to the public. The other is a webinar, another webinar we did on mammography, screening mammography and early detection last year in March. Also another good sort of overview on the issue. There are also 2 good books that you can read. The first is The Big Squeeze, A Social and Political History of the Controversial Mammogram, and the other is called Overdiagnosed, Making People Sick in the Pursuit of Health by Dr. Welch, who was also one of our past webinar presenters. So I want to open it up, and we will open it up to questions in 1 minute, and I see people have been typing in their questions, so thank you so much. But I wanted to give a little bit of information about how you can become a member of Breast Cancer Action. You can sign up for our news and action alert emails on our website at bcaction.org. You can also join us on Facebook and Twitter to connect with others and help change the conversation about the breast cancer epidemic. You can also help others get this information. You can tell your friends, coworkers, and families about this webinar. And last, you can donate to support our educational and advocacy work. And again, I want to remind you, as I did when we started, that Breast Cancer Action really relies on your support to make these webinars possible. Your individual support of our work is so crucial. And if you've been inspired today, please consider making a donation of $25 or more so we can continue these webinars. And you can go to bcaction.org/donate. I want to give a really big thank you to Dr. Miller for his presentation today. And now I'd like to open it up to your questions. Now, the first question is just about getting these slides after the presentation, and we record all of our webinars and make them available on our website about a week after they air, along with a PDF of the slides. So you can check back at bcaction.org/webinars. A lot of really great questions. I'm going to start with one caller says, you were only evaluating mortality, not morbidity. So they're wondering if a cancer is detected earlier when it is smaller, the types of treatment are impacted, and isn't the degree that the patient may suffer from treatments for a larger cancer relevant, or how does that relate to what your study was looking at?
Well, we did look at the treatment. The treatment does not seem to have been very different. Treatment is always given according to what we call stage, and it's certainly true if a cancer gets a bit larger, then it may be necessary to remove a little more of the breast. But one of the problems is that if you actually don't remove enough, you may have to go back and retreat. So in general, the treatment was not really impacted. And one of the reasons for that is because of the short lead time that mammography in fact gives. Now what it actually did was to find a number of cancers earlier than breast examination, and they were treated earlier, but it didn't impact on death. So that means that women lived longer with the breast cancer. And so their life was impacted by breast cancer a year or so earlier. They were aware of it for longer. I think only women have to decide whether they want to have mammograms just to find breast cancers a year or so earlier, even though it wouldn't impact on their risk of death.
Thank you. There's another question that relates to sort of the risk, and someone says, if mammography screening has no effect on important health outcomes for women at average risk of breast cancer, what if we're looking at women, let's say, who have the BRCA mutation and who may benefit from active surveillance, or a population of women who are so-called intermediate risk, and could those populations potentially benefit from mammography screening? And does your study relate to that?
Well, in fact, a number of people have abandoned mammography for the women who are either suspected or known to be carriers of the BRCA1 or 2 genes, or who have a very strong family history. In fact, different approaches to diagnosis are being evaluated. Early diagnosis using MRI, magnetic resonance imaging, very high quality ultrasound. Mammography itself does not seem to be effective. But in practice, screening is a poor approach to dealing with people who are at very high risk. There are all sorts of other procedures which are recommended, and you will remember Angelina Jolie opted to have bilateral mastectomy. She wanted the safety of that because her physicians could not reassure her that screening or particular screening tests, even using MRI, would have necessarily protected her, given her the protection she wanted.
Great, thank you. There's another question that relates again to sort of the population in terms of thinking about screening mammography versus mammography for women who have already been diagnosed and treated with breast cancer. And the question is, what are the implications for patients who have already been diagnosed and treated for breast cancer, who are being followed with both frequent breast exams and screening mammography? And how does your data, the data you found, relate to this population of women?
Our data does not relate to this population at all. We don't really call the screening is essentially surveillance, and it's true that mammography, but often other techniques now are used for surveillance as well as good breast examinations. So you can't apply our study to women who have been treated for breast cancer.
Great. There's a question about the population of women under 40 and if mammography is relevant to that population, and if your study had, if you have any sort of conclusions based on your study for that population.
No, we have no conclusions. We did not study such women. The risk of breast cancer is substantially lower in women under the age of 40. Mammography is universally not recommended for such women. It would be very rash, I think, for anyone to advocate screening. It would be costly for the health system. It's very unlikely to be beneficial. If you can't find benefit in women in their 40s, you're not going to find benefit in women in their 30s.
Great, thank you. So there's a question that relates to what we were talking about, what you were talking about a little bit in terms of looking at diversity of communities, and wondering if the screening trials really adequately included diverse communities in Canada, and is there any reason to think that for women of color, potentially here in the U.S., who are more likely to die of breast cancer, that mammography screening may be beneficial to these populations, especially because when you look at some of the more aggressive breast cancers happening at younger ages in these populations?
Well, I think the most important thing for women who belong to such groups is that they get adequate treatment, that they themselves participate in finding breast cancers early. A breast self-examination, which we used to promote, is not now promulgated, but instead the American Cancer Society, I think rightly, proposes to women that they are aware of the structure of their breasts. They practice what we call breast awareness. If they are in any way concerned about their breasts, if there's been a change or they find a difference between one breast and the other, they go and be examined by someone who understands the signs of early breast cancer. One of the problems is that we have taught our physicians in the past largely in relation to advanced breast cancer. And the signs of early breast cancer are nothing like the signs of advanced breast cancer, and you have to be specially trained to recognize them. And I think this is much more important, both for women in color and for women in diverse groups from other cultures, that they practice breast awareness. They're not embarrassed by having to go and be examined. They go and see a physician who knows the signs of early breast cancer and can advise them.
Great, thank you. I think that's a really sort of common question and struggle here in the U.S. around different populations and the benefits of mammography, but also thinking about how and when women have access and can get high-quality treatment if there's an issue. And I know in Canada that's not an issue, and in the U.S. Currently it is an issue. So thank you for addressing
that. It's increasingly becoming an issue in Canada, incidentally.
Oh, really?
Oh, yes. The same advice I've just given you.
There's another question that's around other other technologies for detecting breast cancer, such as ultrasound or MRI. And someone was wondering if you believe that these might be better than mammography, or are there other sort of screening methodologies that might be a better way to detect breast cancer than mammography?
I don't think so. I mean, there are a number of advances in the pipeline in terms of mammography. We've moved from what was used in our study and universally film screen mammography to digital mammography, where images could be stored by computers. That has practical advantages. The studies that have been done suggest that there's a major disadvantage. It can increase the amount of overdiagnosis. There is another technique in the pipeline which is called tomosynthesis. It involves, in effect, doing scans of the breast and taking metaphorical slices through the breast in the images. This seems to increase again the numbers of lesions found, and I am concerned that it may increase the amount of overdiagnosis. I think we need some very carefully conducted studies to find out if it really is beneficial. And as to MRI or ultrasound, ultrasound has great benefits in terms of trying to distinguish cysts, which are common in the breast, particularly in younger women, from a solid mass, and so it's used for diagnosis. And we've already discussed MRI in relation to the high-risk groups, but neither, I think, are likely to supplant screening with mammography. And as we've already implied today, this does not seem to be advantageous.
Great, thank you. There's a question, and this, I'm not sure if you can answer it, may be more of an individual question, but I think it's a question that comes up a lot, which is that for women who have found invasive cancer through a mammogram, it was not palpable, and then the cancer metastasized, and wondering or feeling that, you know, having the mammogram meant that their, you know, the metastasis might have been worse, or there may have been a greater risk for metastasis if they hadn't had the mammography find the breast cancer. And I don't know if that's a question you can answer or if it relates to the results of your study, but I wanted to pose it.
Well, there is some evidence that this may happen. There are some specialists who've been pointing out there is a possibility if you bring forward the diagnosis of an impalpable cancer, and although you didn't know it, it's already fairly advanced, you could interfere with the immune system in the body and make things worse. And there was a hint of it in our study and some of the other breast screening studies. Now, you'll find most people dismiss this altogether, but we do know that some of the great researchers who found the benefits of modern adjuvant treatment, chemotherapy and hormone treatment, did animal studies and did demonstrate that this could occur in animals. So the really critical thing for somebody who is diagnosed with breast cancer by whatever means is that they are treated by the best treatment as soon as possible.
Great, thank you. Someone was commenting on, you mentioned the signs of early breast cancer, and they were wondering what you were referring to.
Okay. Well, the first thing is, and this is when we taught breast examination, when I've taught breast examination to people, particularly in developing countries, I've done classes of teaching the teachers. What you do, the first thing you inspect your breasts. Stand in front of a mirror. You look for any inequalities in shape, any dimpling, skin dimpling, any difference in the position of one nipple compared to the other. And then you palpate the breast. And this is done sitting up and lying down and on yourself on the side. And what you're essentially looking for are differences between one breast and the other. You're looking for not necessarily a solid lump, because not all breast cancers are solid lumps. You're looking for a sense of hardness, more tissue somehow. It's not the same in one breast as it is in the other. Women will, if they practice this, will learn the structure of their own breast, and providing they do it at the same time, in relation to their menstrual periods, because breasts do change during the period of menstruation particularly, then they should be able to recognize if there's any change. And we have done some studies. There was a good study done in Finland. We did a study within the National Breast Screening Study which demonstrated that the women who practiced breast self-examination well did better than the women who practiced breast self-examination poorly. They were more likely to survive their breast cancer.
Great, thank you. We have a question about, I think that sort of addresses the difference between survival versus mortality. And someone was asking, they say, is it accurate that the average size of the tumor in the study was less than 2 centimeters, and that in the U.S., tumors diagnosed by mammograms are much smaller, and that the 25-year survival for women with palpable tumors was less than 65%, while those diagnosed with mammography and unable to be followed was 80%. I think this gets to the difference between survival and mortality. Can you talk a little bit about that?
Okay. Well, when we talk about mortality, we talk about the numbers of deaths related to the numbers of women. So we look at the numbers of deaths in relation to the 90,000 women in the study, or rather the two groups of nearly 45,000. So that's mortality. Survival is the length of time somebody survives, remains alive after a diagnosis. And if you like, that's related. It's the same death, but you're looking at the individuals who have the cancer. Part of these comments on survival rates and what you quoted are quite out of date, particularly compared to our study. They were much longer than that. But part of the problem is when you include in the cancers found by mammography the overdiagnosed cancers, you artificially increase the survival, because people who have overdiagnosed cancers don't die of breast cancer. And so you essentially making the survival look artificially much better than in fact it is. So you have to be very careful when you're talking about survival. And in general, we don't measure the effect of screening for any cancer by survival, but we measure it in terms of mortality, or for those cancers where if you remove a precursor, cervix and colon, reduction in cancers that occur.
Great. Well, thank you. I think that was our time, and that was our last question. I wanted to thank everyone for their really thoughtful questions and comments. And if you didn't get your question answered today, you can follow up with us at info@bcaction.org. And I want to thank everyone for taking the time today to attend the webinar. And please watch your email for a short survey where you can provide some feedback on this webinar. So goodbye and have a wonderful rest of your day. Thank you.
Okay, thank you. So, have you gone? Yeah.